Stand on the seat, please. Okay, a couple questions during the break, and just to clarify some things, with the wrist fractures, dislocations, when they talk about things are dislocated or are presenting palmarly or dorsally, they're referring to the distal end. So if you have a fracture, they're referring to the distal segment, which way it moved. Okay, so just relative to the proximal segment. Okay, so if for one of those fractures it says the wrist has been dislocated anteriorly or palmarly, it's because the distal end moved forward. Okay. The other clarification was paralunate and lunate. So when they say a lunate dislocation, and this is the website I found it from, this is from Ohio State Medical School. If the lunate is dislocated, they're talking about in reference to the midline of where it should be sitting. So if the lunate is actually off that midline, that's a lunate dislocation. Perilunate refers to the structures around the lunate. Okay, in this particular case, it's a perilunate dislocation because the structures around the lunate have been dislocated. Okay, so I hope that makes a little bit more sense. Okay, so peri means outside or around the lunate has been dislocated. So in this particular case, whereas a lunate dislocation, again, both hyperextension injuries, if this gets moved back, it pushes the lunate forward.
So perilunate dislocation does not actually have to do with the lunate?
No, it's the structures around the lunate move dorsally. So I think that's where the confusion was on the slide before. Okay. So what I drew here is this. So this is what? Is that a lunate dislocation or perilunate dislocation? This is the midline. That's your lunate. That's a lunate dislocation because it's off the midline. Perilunate, the lunate's sitting where it's supposed to be. But the structures around, again, peri means the area around it. The area around it is moved dorsally. So the capitate and everything else above the lunate has been dislocated. Perilunate, lunate.
So that last bullet on that slide is wrong. It's on the right.
So slow, sorry. So perilunate dislocation. Yeah, it's not the lunate displaced dorsally, it's the stuff above the lunate that's displaced dorsally. Okay, so just cross this out. And you can replace that with capitate if you want, because that's the structure above it. Okay. You put capitate, or you can also put distal carpal rope. Is dorsal. Was there any other questions about the stuff we covered earlier? Okay, so we'll continue with hand pathology. So metacarpal fractures, compressive force along the shaft of the metacarpal itself. There's a few that we'll talk about. There's Boxer's fractures, Bennett's fractures, and so on and so forth. So it happens most in basketball. The fourth and this is just general metacarpals. So fourth and fifth are most common. That's your pinky and your ring finger. Those metacarpals are most common. Audible crack. That's what it says in the books. Like I've run into some situations where you don't see or they don't feel or hear a pop, or sorry, a crack. But there's a lot of swelling right away. With respect to sharp, they can't make a fist. You could see a deformity, but the swelling normally covers this up. When it says unable to make a fist, when they try to squeeze, and you can do this in the foot also with the metatarsals, that a lot of times when you palpate for a fracture, most people, from what I've seen, go over the top where the swelling is and they'll push and they're like, I can't really get a positive, but all the swelling is providing a cushion. But if you go underneath and push this way, where there's not much swelling usually, you'll be able to provide a fulcrum, do a fulcrum test by pushing the mid-shaft of the metacarpals, recreating the pain and or crepitus. So you can do that in the foot as well. You can go over the instep, the top of the foot, but if there's too much swelling, if you poke on the bottom of the foot, you're creating a fulcrum that bows the metacarpal bone. Okay. Bony fragments and crepitus, if they try to move their hand, they might report feeling crepitus as well. Okay. The test is axial compression. All that is they have to flex, or if they can flex at their MCP joints, you're just pushing at the knuckle to provide axial compression. Okay. If they can't bend at their MCPs, you can just take their whole finger, just drive it in that way. Okay. Again, I do not recommend doing any of these fracture tests if there's an obvious deformity that you actually see. Just prefer. Immobilize, PMS, prefer. These next few slides talk about specific metacarpal fractures. The first one is your Bennett's. This is the base of the first. Associated with a dislocation or subluxation at the carpal metacarpal joint. So you guys know what I mean by carpal metacarpal? Okay, so that's your metacarpal, your MCP, metacarpal phalangeal. If you go down here at the end of the metacarpals that articulate with the carpals, that's your carpometacarpal. So this is your carpal metacarpal joint. Carpal metacarpal joint. Okay? And that's your thumb, that's your sesamoid bones. And the fracture occurs down here. Okay, usually where it articulates with this carpal bone. What's the carpal bone that articulates with the first metacarpal thumb? Starts with a T. Trapezium or trapezoid? Trapezium, good. Okay, that's the saddle joint. This is problematic because the saddle joint, there's like all these different curves and surfaces that allows it for more degrees of freedom, so it does get pretty complicated if you fracture that. This fracture could extend into the trapezium. Sometimes it does, sometimes it doesn't. Direct blow with an axial force, so that's like one of these. Okay? So the force just transfers all the way down and cracks the base. It's also associated with dislocation or subluxation as well. So again, if you see an obviously deformed dislocation of the thumb, do you want to pop it back in? Probably not a good idea because that might be underneath. Okay. Signs and symptoms, I think, are self-explanatory. Any questions about a Bennett's fracture? Okay, there's Bennett's and then there's Boxer's. Opposite side of the hand. The Boxer's fracture is on the fifth metacarpal. Usually happens when a person grazes what they're trying to punch. Okay, so most of your force when you punch goes through your first two knuckles, right? If you ever try punching a heavy bag with the side of your fist, it really hurts. Okay. That's not meant to transfer any force. So that's what happens. It's called a Boxer's fracture. Depressed fifth metacarpal with a clenched fist. So it's similar to Murphy's sign. So if you do this, you would see a deformity. You might see a deformity, but what you'll see is one knuckle a lot lower, more proximal compared to the opposite side. Okay, so it has to be bilateral comparison when you're doing this. False joint or crepitus, again, it depends on how much swelling there is. You may not see that. Okay, especially if the swelling gets in there really quickly. And then palmar displacement of the distal fragment, and that's what they generally would see. Okay, so if you're looking at anatomical position, that distal fragment, if there's a fracture in the midshaft, that segment will be displaced palmarly or anteriorly. So those are the two main metacarpal fractures. MCP joint dislocations, most common at the thumb. So that's your MCP joint. There's just the one interphalangeal joint in the thumb. That's your MCP, that's your MCP. Metacarpal phalangeal joint. And so this has been displaced. It's kind of hard to tell. It almost looks like it's displaced anteriorly. Anyways, I'm not sure. Volar plate evolves from the head of the first metacarpal. So the volar plate is typically on the palmar side, and if this happens, it'll disrupt that volar plate. Extension and abduction is the mechanism typically. Obvious deformity. How many of you have had a thumb dislocation already? Fingers? Fingers, okay. The thumb, because of thenar eminence and because of the ligaments and the muscles that articulate the thumb, it takes a lot more force to dislocate or damage the thumb. Any questions about the thumb stuff? Okay. Finger pathology. The main thing to get out of this slide is that the middle phalange, the middle one, is rarely damaged. It's usually the proximal or the distal, so it's usually this end or that end that's damaged. This just talks about the thumb and the middle finger for the distal phalanx being most involved. These are the types of forces, and these are the type of fractures. So transverse comminuted fracture. You guys know what a comminuted fracture is? It's like a crush. Okay, it's a crush injury. I'd probably say most of these fractures occur because of longitudinal compression. When people jam their fingers, that's the most common. When people jam their fingers and a fracture is involved, it could result in any one of these fractures. The most severe, I'd probably say, is the comminuted because the bone's in little pieces. Sounds and symptoms. A snap, again, that depends on how people interpret the word snap. You might see a deformity. Malaligned fingernails is something to look out for. So this is a picture of one finger that's been rotated, or is sitting in, rotated, possibly because of a spiral fracture. Okay. Just keep in mind, you have to do this bilaterally. Like, take a look at the other fingers, but take a look at it bilaterally as well. My index fingers are rotated naturally because of playing basketball. Whenever the ball rolls off this edge of my finger, the tendency is for my finger to evolve to turn this way. It's kind of like a bunion for my finger, but it's rotated already. Okay? So take a look at your fingernails, or take a look at your partner's fingernails. Just go like this, and see how level their fingernails are as a baseline. Okay? Just as a baseline. If one of them, again, with the history, observations, mechanism, if one is sitting rotated or tilted relative to the others, relative to the other fingers and relative to the opposite hand, then that is an indication of a fracture. Okay. Now, if it's rotated like that, possibility of a spiral fracture. Could be the other ones as well, but the spiral fracture would allow it to rotate. Okay, so that's an observation you would make if you think it's a finger problem, a potential finger fracture. The vibration test, all that is I mean, if you look at Schultz, they just have, and they do this, they're just flicking the end of the fingers.
Why do people have like curly toes? Like, you know what I mean? Like how toes kind of curl in? And like some fingers as well?
Like hammer toes?
No, but like just like underneath one another.
Yeah, mine do that too.
Like mine do that. Just out of curiosity. Is that kind of like spiral issues or?
No, it's probably just genetic.
That's genetic?
Like unless there's a contracture of some sort or a capsular issue.
So it's like common. You see it.
Like it curls in.
Your chair.
I mean, I've honestly not small. I've always known.
Yeah.
So in fairness, it's like,
Yeah, mine
So it's not because of injury. So if you want to take a look at people's feet, like unless there's a mechanism involved, it's probably just a natural fracture. So, but anyways, a vibration test in Schultz's book, they just have you flick the end. But again, don't just take that one test and say, boom, it's a fracture. Take into consideration, again, the history, observations, palpation, all the other tools, assessment tools that you have at your disposal. Balance dislocations. I don't know what's more common, fractures or dislocations. I think dislocations are more common. Axial load is typically the mechanism, but that is also the mechanism for a fracture as well. Or hyperextension. And these are the structures that are damaged. Things to be aware of, complications of volar plate injury. That would require just a little bit longer of immobilization and then getting the mobs in as soon as the tissues have healed. And then depending if you think that, depending on the person, if they're younger, then you might want to have them x-rayed because of a potential epiphyseal fracture as well. Okay, again, especially involved with the collateral ligaments. Now, I mean, that's what it says in Schultz. To be honest, I mean, who's concerned about the length of their fingers? I don't know. Is anybody concerned about the length if like one finger is?
I'm an artist.
True. Hand models, guitar player. Okay. So, I stand corrected. Right, let's move on. Okay, so the next few slides, there's mallet finger, jersey finger, trigger finger, boutonniere deformity.
Trigger.
I'm just gonna fly through these ones because they are similar to the deformities or whatever you would call them with feet. So mallet finger, mallet toe, we talked about that before. It's just an avulsion of the central tendinous slip. For your extensor digitorum, the C in some books they call it the extensor digitorum communis. Okay, so just make sure you know that. Extensor digitorum communis. And the main thing that distinguishes this from the other ones we talked about is the inability to extend the distal thigh. The mallet finger test is, can you straighten out your fingers? And if you ask them to actively extend their fingers, the inability for them to extend that last interphalangeal joint, again, along with the history, the mechanism, observations, blah, 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 indicates that it's a potential mallet finger. Treatment for this, bring this little bad boy up here and hold it there for 2 to 3 weeks at least. So splint in hyperextension if you think it's mallet finger. Jersey finger, instead of, so mallet finger is an extensor tendon issue, jersey finger is a flexor tendon issue. Yep. So that's the mechanism. You're trying to grab somebody and then the jersey gets pulled, forcing the digits into extension as you are trying to flex. When that happens, the tendon gets pulled off the bone, it's an avulsion. And if that happens, the person will be unable to flex at that joint. So the jersey finger test is, let me see you make a fist. And when they make a fist, and they try to curl these distal interphalangeal joints, the one that's in question will end up like that instead. They won't be able to flex that distal interphalangeal joint. So that is called jersey finger sign. Can you make a fist? Do that. Okay. Mallet finger, can you straighten out your fingers? And they try to do that, and the last one just drops. That's mallet finger. Okay, both of those are a result of trauma. Boutonniere deformity, rapid forceful flexion of extensor, rapid forceful flexion of extensor, that doesn't make sense.
What?
PIP joints. Rupture of central so this is like Jersey finger, but it happens up here instead. Okay. So instead of this tendon, sorry, instead of this tendon being disrupted, it's this one up here. Okay. So what's this trying to say is the person's trying to extend and they get forcefully flexed, and hence their PIP, this joint, falls. Okay.
Is that hard to do?
Is it hard to do?
Yeah.
It usually happens when you're trying to catch a ball. So it'll either be mallet finger or it'll be boutonniere deformity. Okay. If you look at Netter's picture, it'll actually have a great picture of this tendon coming down this way. And then this being a piece of this tendon that just goes to this bone. So if you disrupt this part of the tendon and this one is still functioning, it'll look like a flexure here and an extension down there. So the finger will present like this, and it won't be able to extend at the PIP. It's the exact same mechanism as mallet finger. It just happens here instead of here. Okay. It's still a disruption of the tendon. Whether it be a tendon tear or rupture, or whether it be an avulsion fracture. Okay. The result of this central slip being torn and this one being intact is that this is able to extend, but this isn't. Okay. You'll find a picture like this in Netter's book. That's the middle phalanx, proximal phalanx, distal phalanx. And so what I'm trying to talk about there is that there's a tendon that goes like this. That's the same color, sorry. So there's a tendon that does this. And there's a piece of that tendon that goes like this. So that's all one. Okay. So that's the middle phalanx, that's the distal one. This here are the lateral slips that you see here. And this one up here is this one. So you can tear this and that still be intact. So if you tear this, you can't have extension here. But you can, you can't have extension here, but you can still have extension here. So this will still work, but that won't. So that's what this is trying to say. Okay, you can extend down here. So down here is this. But this won't be working because it's been ruptured. So this is this. Okay. That's called a boutonniere deformity. Okay. Again, the only difference between that and mallet finger is that with mallet finger, this is torn. And so you can't really extend. Extension of DIP and MCP joints, flexion of PIP joints. So that's what it looks like. You'll be extended here and extended there, but flexed in the middle. And we talked about this loss of active extension of the PIP already. Okay. So that's your boutonniere deformity. Trigger finger is a condition where it's called a stenosing tenosynovitis of the finger. or thumb. You guys know what a stenosing tenosynovitis is? What is a stenosis? Narrowing, correct, narrowing. So a stenosing tenosynovitis. Okay, remember how we said that the tenosynovitis, you have a string within a straw. The string is the tendon, and the straw is the synovial sheath, the tenosynovium, if you will. So that string's supposed to be able to move. A stenosing tenosynovitis is where that straw gets inflamed, becomes really, really thick, and gets so thick that the hole where the tendon is gets really narrow. Okay. If that's the case, that string is not going to be moving really smooth within that sheath. It's like de Quervain syndrome, but take that a step further. Right? So de Quervain's is generally just an inflammation of that sheath. In this case, it's an inflammation of the sheath, thickening so much so that the hole where the tendon is becomes really narrow. Okay, so that's trigger finger. Pain with active finger flexion, unable to actively extend finger, a pop with passive. And the pop usually comes because of that narrowing. Okay? Later on, if you get a chance to just click on that link, it's actually just a quick little clip of what it looks like when someone's trying to open and close their hand who's got trigger finger. This is not a direct trauma, it's progressive. Happens in a lot of elderly people. Okay. So what you'll see happen in this is when they try to open, when you click on that link, there's going to be someone doing this. And what you'll see is that their fingers, typically the fourth one, third or fourth, with this one and with the video, it was the fourth one. As they open, it'll delay and it'll stutter before it opens all the way. Okay, in some cases, it won't even open all the way. They'll just do this. It'll get caught. Okay. The trigger finger test involves them opening and closing their hand while you just palpate over the flexor tendon. Okay, it's a flexor tendon issue. Okay, so watching the finger not being able to open up along with pain underneath where you're palpating is a positive for trigger finger. Okay, so treatment-wise, what do you do about this? If you look at what it is, we need to remove the inflammation. If it's a thickening of the inflammation, we need to heat and break that down. So ultrasound, thermal, frictions, can't really use the term active release, but deep tissue release, you put pressure while the person opens and closes. You can do it actively or passively to get it moving again, to help mobilize the tendon within that sheath. Okay. The main problem though is the stenosing part. It's been narrowed, so you need to break down the tissue that's causing that narrowing and or manage the inflammation that's contributing to that. That's trigger finger. The video link up there is, again, the video of the person opening and closing their hands, so you can actually see how it looks. Thumb sprains, ulnar collateral ligament of the MCP is the most common. Hyperabduction, hyperextension, repetitive stress, also known as gamekeeper's thumb, also known as skier's thumb as well. Ulnar collateral ligament, did you guys go through this with Dale in taping class and why you would tape in that position? Okay, because the ulnar collateral is this ligament. Okay. Hyperabduction, hyperextension. Okay, so if you pull the thumb back this way or this way, you're going to stretch this ligament. Okay. Adduction, extension. Okay, we'll go through ranges of motion because I think that confuses a lot of people. But that is flexion. No, sorry, that's flexion, that's extension. And that's adduction, and that's adduction. Okay. So it's going to damage the ulnar collateral ligament, which is on the side of the thumb. So gamekeeper's thumb and skier's thumb. If you think about ski posts like this and they get trapped, if they get stuck, it'll torque your thumb in this direction. Gamekeeper's thumb, I think, comes from a glove where if you don't time it right, the ball or implement will hit the glove and cause the glove to wobble in this direction.
Some of the articles that I read for the presentation said it's from like people having to catch their game and kill them, actually screws up their necks and
Fabulous.
What?
Game as